Good afternoon. I am Dr. Swapnil Kothari, and welcome to the instruction course on Tariq IOL's markings and current and future technologies. Myself, Dr. Swapnil, I am a anti-segment surgeon based out of Jalgaon, Maharashtra. I have my own private practice. Next, we have Dr. Bhagyashri Deshmukh. She is also an anti-segment surgeon practicing in her own practice at Amravati, Maharashtra, and we have Dr. Narendra Verma, who's an excellent innovator. He is practicing in Gujarat. So I would first like to invite Dr. Narendra Verma to start his presentation.
Good afternoon, everyone, and thank you, Swapnil, for inviting me for his IC. So multimodal approach to management of astigmatism during cataract surgery, past and future of the same. So I have to speak on understanding astigmatism, type and prevalence of astigmatism, diagnostic method for astigmatism assessment. So I will cover some basic steps or basic things also. So as a refractive error, astigmatism is of following type, and simple, compound and mixed, all of these are regular astigmatism. So regular astigmatism is more common. In this, there is bow tie pattern, and the steep axis and flat axis are perpendicular to each other. On the other hand, irregular astigmatism is less common. It may be due to corneal pathology like keratoconus, PMD, corneal injuries or infection like HSB keratitis, corneal surgery like PKP, DALK, delayed keratotomy, and also after post-operative ectasia. So sometime in the regular astigmatism, there is bow tie pattern but skewing of the axis. If skewing is up to 20 degree, it is considered as regular astigmatism. So correction of astigmatism, as you know that regular can be corrected by spectacles, contact lens, refractive surgery, ICL, and during cataract surgery we can correct the astigmatism by using by implanting toric lens, which is the most accurate best method. And if it is not accessible, then some part of the incision, some part of the astigmatism can be corrected. Some part of the astigmatism can be corrected by the incision on the steep axis. For irregular astigmatism, some part can be corrected by the contact lens, scleral or RGP, or topo-guided refractive surgery. Depending on the topography pattern, astigmatism is of following type. The upper 5 picture in the first row, they are of regular astigmatism type, and lower 2 rows are of irregular astigmatism. As a wavefront, astigmatism is inducing low order aberration, which can be corrected by spectacles. So this is, we are measuring the astigmatism. So these are different part of astigmatism. So anterior corneal astigmatism. So every machine which is doing keratometry will measure the anterior corneal astigmatism. Then there is some posterior corneal astigmatism is also there, and vector summation of anterior and posterior give the total corneal astigmatism. So when we take any incision on the cornea, when we do surgery, there is some surgically induced astigmatism will be induced, and the vector summation of total with SIA will give you the net corneal astigmatism. This term is commonly used in Barrett toric calculators. So net corneal astigmatism. So anterior plus posterior plus SIA is equal to net corneal astigmatism, and if we neutralize this by toric lens, we will get total emmetropia if it is totally neutralized. Depending on the location, anterior corneal astigmatism is of 3 types. With the rule, when the steep axis lie between 60 to 120 degree. Against the rule, when it is 0 to 30 and 150 to 180, and the remaining is oblique. So posterior corneal astigmatism, it ranges from 0.28 to 0.78 diopter. It is steeper in vertical meridian in majority of the cases, in more than 80% of cases. Its surface is concave, so it acts as a minus lens. Though it is vertically, it is curvature is vertically perpendicular, but it act against the rule. Dr. Douglas Koch, he examined the posterior corneal astigmatism in large number of population, and he gave us this Baylor nomogram, in which you will get the effective IOL position if the astigmatism, anterior corneal astigmatism is with the rule or against the rule, in how much amount and how much will be the IOL power. So if you can get the IOL power. So what is the relation between anterior posterior? When anterior corneal astigmatism is with the rule, posterior is in a small amount, but it is there and it is against the rule. So posterior will decrease the anterior. So when anterior is with the rule, posterior, which is against the rule, it will decrease the anterior, and total is less, total corneal astigmatism less than the anterior corneal astigmatism. So in these cases, the total corneal astigmatism is less, so we have to undercorrect it. When the anterior corneal astigmatism is against the rule, posterior, which is also against the rule, it will add, and the total corneal astigmatism will be more, so we have to overcorrect it. If you have noticed in your autoref reading, autoref keratometer reading, there is difference in the cylindrical power of the autoref and auto-K. So in this case, in the right eye, autoref reading is 7.5 and auto-K reading is 6.5. So the difference is 1 diopter. This difference is due to posterior corneal astigmatism. There is lenticular also, but it is not, in majority of cases, it is not there. So this is just basic idea that there is something like posterior corneal astigmatism. At present, there is no need to use the Baylor nomogram, because in the toric calculators like Barrett toric calculators, the Barrett nomogram is incorporated, and so there is no need, because if you want to find out the IOL power in with the rule, against the rule, it is possible. But you will find out the IOL power by Baylor nomogram in the oblique astigmatism. Lot of mathematical formula you have to use. So there is no need to go for this. You just go in the Barrett toric calculator. The Baylor nomogram is incorporated in it. These are some common instruments which are used for keratometry. So one is manual keratometer, auto keratometer, optical biometers, topographer, and pentacam. Out of these, the newer optical biometers and pentacam, they are measuring the posterior corneal astigmatism also, posterior curvature also. So they will give you total corneal astigmatism. So this is the principle, how they act, and how these are the different type of the keratometers and topographers which are used in measuring the total corneal astigmatism and anterior corneal astigmatism. So manual, previously there was manual, then came the automated auto-K, and then IOL master. So these IOL master, previously they were measuring on the anterior surface, then ORF scan. So they were, when we are putting the slit on the cornea, so we can find out how much will be the thickness of the cornea. So ORF scan, using that principle, they measure the thickness of the cornea, and then they measure the posterior curvature. Then came the same flux technique, pentacam, then Galilei, which is using 2 cameras, so on. Out of these, only Cassini is measuring the anterior surface by Purkinje 1 image and posterior by a Purkinje 1 image. So it is the measuring the anterior and posterior by the Purkinje images. Other are measuring the posterior by the OCT based method, morphological based method. So everyone can't access so much high-end machines, those who are not having high-end machines. So how they can measure and how they can decide whether I should put this toric lens in this patient or not. So there are some, those who are having only manual keratometer and auto-K. So these are some points. So when you can do the toric lens. So you can do toric lens when the astigmatism is regular and your keratometer reading is precise. So how I can achieve it in majority of my cases with basic instrument, if I am having only manual keratometer and auto keratometer. So there are a few suggestions. You have to use 2 instruments, so which are based on different principle. Then keratometry should be done before putting any eye drops or before any contact procedure. 3 identical keratometer readings are considered as reliable. So there should be no difference in the axis. There should be no difference more than 0.5 diopter, 0.1 diopter of the cylindrical power, and keratometry should be done at 2 occasions. So you can repeat on the day of the surgery when you have keep the patient for toric lens in the morning. You can repeat it. Then you have to compare both eyes keratometry. So mainly the steep axis. So what happened? I have shown this case. In this, if you compare the keratometry axis of the anterior surface, in the right eye it is 168, in left eye 8 degree. They are mirror image to each other. If these type of reading are there, in this you can see the keratometry, autokeratometer, the readings are consistently same, axis is linear same. So these type of reading are there, and opposite eye also showing same type of axis, then you are perfectly, there is no need to do topography or examine the patient on higher machines. So you can go in this patient with the toric lens implantation. So in 90% of cases, in the young patient, you will get these type of results. If there is keratoconus or something else is there, then this will not be there. Axis will be different, the readings will be different. Now, what is the aim of toric lens? So toric lens, as we know that net astigmatism consists of, net corneal astigmatism consists of anterior, posterior plus SIA. So toric lens is there to neutralize that net corneal astigmatism. And those who are, sometimes patient can't afford the toric lens, and surgeons, they are not implanting the toric lens, they can correct the astigmatism, or they can reduce the astigmatism by taking incision on the steep axis. So incision on the steep axis, if the incision SIA of your incision is similar to that total corneal astigmatism, you will get the ametropia. So here SIA is decreasing the total corneal astigmatism. In toric lens, whatever net astigmatism, which was including SIA also, we were decreasing the net astigmatism. So for the steep axis incision, you have to take incision on the steep axis. So marking of the steep axis is there. Then you have to customize your incision. Size of the incision should be of proper size so that it will induce the SIA, which is equal and opposite to the total corneal astigmatism. And this is the hardest part, that what should be the size of the incision. So for that we developed this SIA calculator, and it will provide you all these results. It is easy to access. You have just to scan barcode, and you can enter the data in the data sheet, and you will get the results. So it is including the Warren Hill SIA calculator, all the results which you will get from Warren Hill SIA calculator, you will get. An extra polar method is also there. So thank you.
Thank you, Dr. Narendra. So I'm Dr. Swapnil. We'll be covering preoperative markings and the formula in this. So coming to preoperative markings, you have multiple methods of doing the preoperative markings. One is, so you have basically taken care of, you understood what is astigmatism and what is the different type of astigmatism that you are supposed, or you will be planning to correct. Then intraoperatively, preoperatively, you have to mark the patient before, if you are not using any automated machine, then you have to mark the patient. And in preoperative markings, you have multiple methods. You can use freehand marking, you can use slit lamp assisted marking, you can use smartphone based things, as well as a new thing which has been devised by one of our ophthalmologists, which is called as STORM. So freehand marking, you can mark anywhere. This is basically a shoot first and ask later approach. Mark anywhere, take the patient to the slit lamp and find out where your marking has been done, and then intraoperatively take your Mendez ring and put it across there, and from there you recursively calculate where your toric IOL is supposed to go. Second is slit lamp assisted marking. This is a marking which you want to do when you want to mark everything preoperatively, where your incision is supposed to go, where your toric IOL is supposed to go. So in this you can use our normal slit lamp at a very thin long slit. The slit should be bisecting the cornea and it should be going through the Purkinje image, first Purkinje image, for it to be, kind of useful. And what you can do is use a small 30 gauge or 26 gauge needle to create a small epithelial defect where your slit lamp marking is going, where your slit lamp light is going. You can create a very small thin epithelial defect there, and later on you can use your normal marker pen to kind of mark the slit, so mark the scratch. So that will give you a very good retained marking, and it's a very thin marking, so it will not really cause any problems intraoperatively. Another option that you can use to mark 0, 90 and 180 is air bubble marking. So in this air bubble, which is at the center of this instrument, is you have to keep it within those two lines, and that ensures that you are at 0, 180. But the problem with this method is it is a highly operator dependent method. Similarly, pendulum marking is there, in which the pendulum is supposed to keep the marker properly horizontally aligned. The only issue is you have to make sure that the pendulum is not touching the cheek of the patient. Dr. Akahushi has developed his own Axis one-step electronic toric marking device. In this, basically what it does, it gives you a visual clue. So this is a simple device in which the patient is sitting upright before the surgery, and you have to turn the dial towards the proper marking that you want to make. Once that is done, this light in the center will turn green or red, green, orange, red, depending on how much your hand is tilted from 0, 180. So once you are at 0, 180, the light will be green and it will beep the least. In orange it will beep little more, and in red it will beep even more than that. And this can be calibrated to 0.2 degrees. So it is a extremely accurate device which is again available. Storm is a invention by one of our own ophthalmologists in India. It's a slit lamp based marking device. It's a marker which is fitted in the calibration slot of our slit lamp, and it basically minimizes the operator related errors, operator movement related errors that can creep in when you are doing a bubble marking or when you are doing any of the other markings. And the accuracy is up to 2.4 degrees plus minus 1.96 degrees. It's a very simple and convenient device to be used. Smartphone, we have iToric Patwardhan. We are launching a new device in the market very soon. It is going to be called Precision Anywhere. So we'll be covering that in the talk number 5, since that is covered with there. Coming to formulae, Barrett's formula is the one which is most commonly used. It's a formula which is based on Gaussian principle of ray tracing, and the ELP prediction is based on a theoretical model. It accounts for changes in the principal plane with different IL powers, different IL types in terms of biconvex or meniscus, and also any change in the vergence. And it requires no special constants or modification to the formula depending on what type of IOL you are using. There are 4 types of Barrett's which are available: Barrett toric, Barrett Truquet and Barrett Truquet toric are the most important when it comes to our talk right now. Dr. Bhageshi will be covering that. And then you have another formula which is very accurate, which is called as a Kane formula. It is an AI plus theoretical calculation formula. It has non-toric, toric and keratoconus variations, and it also gives comparable accuracy as compared to Barrett. But the main problem with Kane formula is it doesn't come integrated into many machines, many optical biometers, while Barrett is now almost standard in all the optical biometers that are coming. So I would invite Dr. Bhageshi to take the thing forward.
Excuse me, Mark. A very good afternoon to everyone. First of all, I would really like to thank AIOS for giving me this opportunity and Dr. Swapnil for including me to this instruction course. My topic is surgical management of astigmatism during cataract surgery. So today, due to expectation of perfect refractive outcome, management of astigmatism has become an integral part of cataract surgery. So is astigmatism really our enemy? Should we be even chasing the smallest amount of astigmatism? And why should we worry about astigmatism so much? So actually the small amount of astigmatism, let's say less than 0.5, it actually helps us in increasing our depth of focus. But if the residual astigmatism after cataract surgery goes up above 0.5, the distance visual acuity goes down and the spectacle dependence increases. And it is shown in multiple papers that if the residual astigmatism is more than 0.5, your premium IOLs will lose their wow factor or lose their sheen if your residual astigmatism is more than 0.5. So astigmatism is not really our enemy, but we would like to keep it under control, less than 0.5. So to deal with astigmatism during cataract surgery, we have broadly these two options, the incisional methods and the lens-based methods. In incisional methods, we have on-axis incision, paired opposite clear corneal incisions, limbal relaxing, and arcuate keratotomy. In lens-based procedure, of course, we have toric IOLs. So it's good to know our prevalent practice patterns. This is a survey done by American Society of Cataract and Refractive Surgeons. And basically in this survey, they have divided the astigmatism into 3 categories: mild, moderate, and severe. And for each category, they asked the surgeon that how would they deal with this astigmatism. So for low astigmatism, 0.75, a large chunk of surgeons said that they would do incisional, and small amounts even said that they would not even treat that amount of astigmatism. When the astigmatism goes to 1.25, most of them said that they would go for toric. And when the astigmatism jumps up to 3 diopters, almost all of them said that they would go for toric IOLs. So the first option we have for mild astigmatism is on-axis incision. So it's very simple that you take your phaco incision on the steep axis. In elderly cataract patients, most of the time your steep axis is 180 degree. That is against the rule, and that's why most of us take temporal clear corneal incision. But when the steep axis is at 90 degree with the rule, I most of the time change my surgical position to superior, and it controls like little small amount of astigmatism up to 0.5 diopters. The next option we have is paired opposite clear corneal incisions. So this is very simple and cost-effective technique. It does not need any extra instrument. Here at the end of surgery, we can see the lens there. I'm under continuous irrigation. I'm just poking the keratome opposite to the original phaco incision, and these are the grossly this much flattening it causes for 0.75 for against the rule and 1 diopter for with the rule. The next tool in our armamentarium is limbal relaxing incision. It basically treats the astigmatism at corneal level by taking incision, the partial thickness incisions at the steep axis. It can be done manually or femto-assisted, but for the sake of practicality, I'll just stick our discussion to the manual LRI. It works very well till 1 diopters. You can do it for higher than 1 diopter, but the predictability above this for the higher astigmatism, the predictability goes down. And remember that LRI should be avoided in thin irregular corneas. These are the 2 nomograms, Donenfeld and Dono, or Nichamin age or Pachy adjusted, or Napa nomogram. These are very important nomograms for a surgeon, but what I do nowadays, I just go to LRI calculator, put in the data, and the site gives me pictorial depiction of LRI incisions. So just to compare the 2 nomograms, the Dono nomogram does not allow you to overlap the LRI incision with the phaco incision. So for this patient, when I did the calculation for 1.25 cylinder, Dono nomogram gave me the 30 degree phaco incision on one side and 85 degree LRI on the other side. So this, it does not allow you to overlap 2 incisions. So this limitation This limitation causes it does not correct more than 1 or 1.25. For the same patient, I did calculation with NAPA, and NAPA gives me two symmetrical 40-degree incision, one of them overlapping with the phaco incision. So most of the time I follow this NAPA overlap technique, and this is how I do it. Initially at the start of the surgery, rather than doing the full arc, which is required, I just do the partial 30-degree arc, which is usually the breadth of phaco incision. And from that partial arc, I just do my phaco incision from the base of LRI. You have to correctly delineate the base of LRI. And after completing the surgery, I'm just extending the LRI incision to the desired arc length at the end of surgery. So basically, initially, you do one side just the phaco or phaco breadth, and later you extend it to desired arc length. Now we come to the big daddy of them all, toric IOLs. Toric IOLs have definitely established themselves as the most effective way to treat moderate and severe astigmatism. It's the procedure of choice for that category. And I'm just going to go through a few frequently asked questions and try to answer them in practical point of view. Of course, you can add the questions at the end of the session. So which calculator to be used and why? Already Dr. Swapnil has covered it, but still I'll go quickly through it. Many reasons, but the main reason is that it includes all these important parameters. And the most important of them is posterior corneal astigmatism. Dr. Narendra has already touched this topic, that it is a minus lens and it acts against the rule around 0.3 to 0.5. And during calculation, if we ignore the posterior cornea, just consider anterior keratometry, we'll end up overcorrecting with the rule and undercorrecting against the rule. So what does this mean actually? I'll just depict what I mean by this. I have taken two patients. In patient 1, Sandhya, 0.9 diopters of astigmatism, which is against the rule. And basically the anterior against the rule will add up to posterior against the rule, and we'll need more cylinder to correct this. We'll need around 1.5 diopters for this cylinder at the IOL plane. But the patient 2, Gopal, has the same amount of cylinder, around 0.9, but the direction is with the rule. So this with the rule will get negated by posterior against the rule, and we'll need less amount of cylinder. Actually, for this case, we do not even need a toric IOL. So this is well taken care by Barrett toric calculator. The default setting in the Barrett toric calculator is that it gives you predicted PCA by theoretical formula. But it also has an option of measured PCA. That means if you have any machine like Pentacam, Galilei, where you can measure the actual PCA, you can enter those values, and the calculator will consider those values for the final calculation. The one more important feature of Barrett toric calculator is something called integrated K. Usually we have multiple machines and they give slightly different K readings, and you are confused at which K reading to be used. So basically this calculator has an option that you can enter 3 to 4 readings from different machines, like I have entered here from Lenstar, autokeratometry and Pentacam, and the calculator will give you the integrated K, which will be used for further calculations. SI is very well covered by Dr. Narendra. I'll just quickly go through it. Which value should be entered for SIA in Barrett toric calculator. So the first best thing you do is that you do your vector analysis by comparing pre-op data with the post-op data on this website. But if you cannot do it for some reason, then the next best thing you should do is you can use the value 0.1 if you are doing the small clear temporal corneal incision. So this value basically comes from centroid SIA. This is from Alcon calculator, and this explains it very nicely. That if I do 2 patients, suppose patient A, I induce 0.35 at 20 degree, and in patient B, I induce 0.35 at 110 degree. So traditionally, the mean SI is 0.35. That is just an arithmetic mean. And that's what we have been doing since many years. But if we plot these 2 patients on double vector diagram, the direction of these 2 patients are exactly opposite, and in vector analysis, they cancel each other, and that's why the centroid SI is 0 here. And this is what we need for our toric calculation, the centroid SIM. And the next final question is, which cylinder power should be chosen between these three suggestions given by the calculator? So the original thought was that the original axis of the patient, the astigmatic axis, should not be flipped. It should be kept after the surgery. This patient, for example, has steep axis 0, 180 degree. And when we use 2.25 cylinder at IOL plane, the residual is 0.5 and we are retaining the steep axis against the rule. But if we use the higher power 3 cylinder, we are flipping the axis to 90 degree. Now the astigmatism is with the rule and residual is 0.1. So there are two advantages of keeping the patient with the rule, minimal with the rule. One, that it gives a slight depth of vision to the patient, and two, there is a continuous shift with the age towards the against the rule side on the cornea, and this shift is taken care by residual with the rule. So this is how I implant my toric IOLs. I usually implant it under continuous irrigation. The most important step in toric IOL is the size of your axis. It should be around 5 to 5.5 millimeters so that it overlaps your optics from all directions, 360 degree. That will significantly decrease the chances of rotation. I use my irrigation aspiration cannula itself to rotate the lens to the desired position. And once the lens comes to the desired position, I keep my continuous irrigation on and hydrate the main port and the side port. With this method, you do not get any fluctuation in the anterior chamber. And finally, before closing, just rechecking the axis. You should keep on rechecking your axis and your position of the lens until the end of the surgery, until you remove your speculum. And with this, I think you will get the perfect outcome in all your toric patients. Thank you very much for patient listening.
Thank you, Dr. Bhageshi. I now invite Dr. Narendra to give his second talk.
So now, management of astigmatism, we will discuss about the intraoperative tips and complications, post-operative monitoring, and managing of the residual error. So,
these are some intraoperative tips which prevents rotation of toric lenses. Proper size of incisions. Main incision and side ports should be little longer. Shorter tunnel may cause leaky wounds and AC collapse. CCC should be smaller, round and central. It should be between 4.5 to 5.5 millimeter so that there is capsular coverage from all sides. Complete viscoelastic removal from front and back of the lens. Hydroimplantation of toric IOL is better option. Tilt the lens, move the irrigating cannula behind the lens and wash all the viscoelastic properly. Fill the AC with air bubble and nudge the IOL to the posterior capsule. After hydration of the wounds, form the anterior chamber by VSS. Avoid overinflation of the AC. Remove the speculum slowly. There should be no pressure on the globe while removing the speculum. Patch the eye for 2-3 hours. Use hydrophobic acrylic lens as they are having high adhesive property.
Though every time we will not get the uneventful surgery, sometimes there are complications. These are some of the complications. We will see how we will manage these complications. So when we are doing manual marking, there may be a smudging or wipe out of the marks. So when we will shift the patient to the OT, before shifting the patient to the OT table, you check the operative reference marks. So if reference marks are not there in the OT, even in the OT, let the patient sit, you can do 180-degree marking, freehand marking is possible. As Dr. Swapnil told, that it is better to use 26 number needle for preoperative marking because they will last longer and they will not wipe out. So we can overpower this problem by using 26 number needle for preoperative marking. If CCC is extended more than 6 millimeter, it may happen in hypermature cataract, or sometimes patient move his eye when we are doing CCC. So if extension is more than 6 millimeter and if extension is not in the toric lens axis, then you can easily implant the toric lens. If it is in toric lens axis and it is extended up to equator, then better to not to implant the toric lens. If the CCC is smaller than 4 millimeter, in young patient, later on there may be capsular phimosis which can cause lens tilt. This is the very dreadful situation when there is PC rent in toric lens. So if there is a small PC rent in the center and you are able to convert it into PCCC, then it is better to convert it to PCC and put the lens in the bag. If it is oval, then do thorough anti-vitrectomy, put the lens in the bag, and it is not in the steep axis of the lens, then only you can put the lens. Otherwise, don't put the toric lens, you can put the monofocal lens, because you can put the monofocal lens haptics in the, not in the extension of the PC rent. Sometime when we are very unlucky, so when we are washing the viscoelastic behind the lens, then there may occur the PC rent. So if the PC rent occur and there is no disturbance of the hyaloid phase, just put the air bubble and don't do any extra maneuver. If there is vitreous in the anterior chamber, so better is to do pars plana vitrectomy. If you will go do anterior vitrectomy, there may be more vitreous will come in the anterior chamber and less dislocation may happen. For intraoperative miosis, as you know that you can use iris hook, rings like Meligan ring, B-hex ring, whatever is comfortable in your hands. When there are weak zonules, there are two types of conditions for weak zonules. It may be traumatic, maybe iatrogenic at the time of doing phaco or washing the, during IA or removing the cortex. You may mistakenly hold the anterior capsule, or it may be traumatic. In these cases, if the zonal dialysis is in 1 or 2 clock hour, you can put CTR ring, very easy to put the CTR ring, but avoid putting the CTR ring if the case is of pseudo exfoliation, because in future there may be displacement of lens back complex and use of CT segment. If you are having confidence enough and you are having posterior retinal surgeon backup is there, then you can go for the CTR ring or something. When there is extent back, mainly in the high myopes, so in this type of cases, don't use the plate haptic lens because they are prone to rotate. So whether to use CTR in extended back high myopes or not to use, so there is one study, and the result of the study is there that there is no statistical significance by putting the CTR ring. Some experts, they are saying that when we put the CTR ring, it will extend the back and lens will rotate more. So they are saying don't put the CTR ring, but don't overinflate the anterior chamber. So if anterior chamber is overinflate, the lens will freely move. So the pressure in the anterior posterior chamber will be equal. So the anterior and posterior capsule, they will in opposition with each other, and they will prevent the rotation of the lens, and keep the patient admit for 2 to 3 hours in the hospital and pass the eye. And before discharging the patient, you can check the patient on the slit lamp. Intraoperative misalignment is also possible. These calculators, they are having, when you will enter the axis wrongly or enter the wrong, if the difference between the steep and flat axis is not more than equal 90 degree, then the calculator will tell itself that there is some error. But what happened, main mistake is that keratometer, in spite of flat, you are optometrist, he will enter the steep axis. In spite of steep, he will enter the flat axis. So total 90-degree difference is there. So in your one suggestion is that in your case papers, you enter the keratometer data. With that, if the autoref reading is possible, some patients, those who are not having very mature cataract, autoref reading is there. So its steep axis lie in the plus cylinder, and so that will also give you an idea of where is the plus cylinder and where is the steep axis. So flipping, we are putting the lens in the steep axis, we are putting the lens in the plus cylinder of the autoref reading. So post-operative monitoring, so maximum rotation occur in first 1 to 2 hours. So you can pace the eye, those who are, you are suspecting that rotation may occur. So if proper coverage of lens is not there in all the on sides, you can pace the eye, keep the patient for 2-3 hours, then you can discharge. If after 1 week patient came to you, patient is not satisfied with his vision, vision is less than 6/9, and there is misalignment more than 10 degree. Some patient, they are not bothered about this, their vision may be less, but they are not bothered. So don't try to tell them that there is you can locate the, or you can again rotate the lens and decrease the refractive power. And one thing I will try to tell you, that you can add one sentence in preoperative counseling, that presently you are putting the lens, you are just targeting the power of the, you are correcting the power, you are not correcting the axis. So after 7 days you will I will take you in the operation table, and then I will adjust the axis. So if by chance there is need to realignment, so patient will not think that you are doing surgery again, there is some complication. So that you can add in the, that sentence you can add in the pre-counseling. So realignment, what is the option? If there is residual error, so if the toric lens, there is residual error, how we can reduce the residual error? So one is the realignment. So in which condition realignment is possible? In 2 conditions it is possible. One, the spherical equivalent should be less. And second, if the axis of the current axis of the IOL is on the is on the steep axis of the cornea, then there is no use by realignment of the lens. So spherical equivalent should be less, and toric lens should be not on the steep axis of the cornea. In the case 1, the spherical equivalent is minus 2.62. So by rotating the lens, you can just decrease the cylindrical power. You are not going to improve the visual quality of the patient. In the case 2, the spherical equivalent is minus 0.5. So you have to check the position of the current position of the lens. If it is not on the steep axis of the cornea, realignment is possible. So for check how you can measure the current axis of the toric lens, it is very easy. So make a slit, dilate the patient, make a slit, adjust it on the mark of the lens, and there is a compass, rotating compass in the upper part. So you can check how much is the axis. If you are having retroillumination mode in your autoref, you can take the retroillumination picture, and by using the compass you can also mark this. You can find out how much the current axis of the toric lens. Eye trace is the very good instrument to measure the current axis. It also provide you, do the abrasions at the corneal level, at the lens level, and also provide you how much axis rotation is required. So, but it is very costly instrument, not able to all of us. So for realignment, there are 2 formulas, formula available to us. One is astigmatism-fix.com, and second is Barrett RX formula. So we will compare these 2. In the astigmatism-fix.com, you have to enter only post-operative refraction. Then what is the current position of the toric lens, and what is the power of the toric lens you have implanted. So, and the result you will get, how much will be the realignment axis. In the Barrett RX formula, addition to this, you have to add pre-op keratometry, their axis, axial length, ACD, lens thickness, incision location, and incision SIA. all these things which you have entered in the body calculator. So no addition data is required. Whatever you have added in the, whatever you have entered in the, where you have done calculation during calculating the toric axis of alignment, Barrett toric calculator, you have to enter all data. Extra data is only one, post-op keratometry. So you have to enter post-op keratometry. It will provide you two additional results. One, you will get the exchange IOL and piggyback IOL. Realignment of the toric lens to the new axis. When should be done? You have to done as early as possible if there's gross error. So there is transcription error, 90-degree flip is there, then do as early as possible. So late more than 2 weeks is advisable if there is in the high myopes, the bag is very large, and if you realign, it will, you can rotate. So let the bag shrink a little, then after 2 weeks it is advisable to realign the lens. So how you can realign the lens? It is preferred that you use only the bimanual IA and realign the lens. If it is more than 1 month, then visco separation is needed because there are adhesions. So if realignment, these are the options to correct the residual error. Realignment, if realignment is not possible, IOL exchange or piggyback IOL. If you are having access to the LASIK laser, then you can go for corneal ablation procedure also. So I want to compare the Barrett with the astigmatismfix.com. Consider this is a case in which post-op refraction is -2 diopter spherical with +3 cylinder. So when we enter the data in this Barrett toric calculator, it provides us that there is rotation from 60 degree to 105 degree. So if we rotate the lens from 60 to 105 degree, it will decrease the refractive error. So it will also give the how much refractive error will decrease. And at the same time, the upper part, left upper part, it is also providing us that if we want to change the lens, so what will be the power of the lens, new lens, and what will be axis of the new lens. And the second picture, it also provides us the piggyback IOL. If we don't want to rotate the lens, we can put the piggyback lens. So what will be the power of the piggyback lens? Its axis. But if the cylindrical error is there, cornea is cylindrical, toric lens is cylindrical, and if you want to put cylindrical piggyback IOL, so it is a little complicated. There will be complications. So better to go for lens exchange. This is astigmatismfix.com. In this, only few data are required. It gives us the how much rotation of the current IOL position is 60 degree. Ideal IOL position is 104 degree. Here it is telling. So how much rotation we have to do, and what will be the residual refractive error. It is telling us only two things. Let us compare these two calculators. So in the astigmatismfix.com, in the same case, if I am taking ACD 3 millimeter, so it is telling that axis of IOL is current. You have to rotate it to 104 degree, and residual will be remain 1.05. If I enter this data in Barrett, Barrett will tell that you have to rotate the lens to 105 degree, and residual will be 1.11. If I increase the ACD from 3 to 6 millimeter, considered as a hypothetical case, so there will be no change in the astigmatismfix axis, new axis, and residual, because it is not considering ACD. But in the Barrett, previously it was 105, now it is 107, and residual will also increases from 1.11 to 1.35. So axis rotation is increased and is changed by 2 degree. This is due to the ACD. So these parameters are not included in the astigmatismfix.com. They are included in the Barrett. So Barrett is anyway better than astigmatismfix.com, but data entry is easy because only 3 data are required to find the new axis of alignment in the astigmatismfix.com. So that is easy to use, but it is better to to do the Barrett RX. Thank you.
Dr. Narendra. Thank you, Dr. Narendra. So we are coming to the last talk of this IC. So till now we saw what is available, and next we are coming to the future trends, emerging technologies and innovations in the management of astigmatism. So what we have, we saw the manual methods. Now we are going to smart manuals, something coming up, toric guidance systems, which we have, the role of capsulotomy, then something even more interesting, which is light adjustable IOLs, something perfect lens technology, and lyric. So what are smart manuals? Manual is basically you are doing the manual marking and trying to calibrate it with using some smartphone apps. The most common one in India which is being used is iToric Patwardhan. This is a free app which is available on iOS as well as Android, and it has been developed by Dr. Saurabh Patwardhan. It's excellent in terms of usability, but requires a trained person to operate. So this is how you basically use iToric for doing a manual marking. You mark freehand, and once you have done the marking, you have to take a picture. The iToric Patwardhan gives you this kind of protractor over the image. You have to adjust the protractor and pinch the cornea, pinch so that the cornea fits in the outer circle and the center of the pupil. Then you have red marks, which these red dots that you have to align with your ink marks. So these red dot, from the position of these red dots, the iToric Patwardhan gives you exactly where your marking is and what kind of error that you have induced while marking for this particular patient. And from that you can recursively calculate, and it recursively calculates and shows you where your IOL is supposed to go. This is another software that actually we are developing. This is going to be called Precision Toric Anywhere. It is right now in a pre-launch phase. The system is similar to Saurabh Patwardhan's system, in which you do your ink mark as per your routine practice. You can do 3 ink marks, you can do 4 ink marks, you can do 360-degree ink marks. It doesn't really make a difference to this software. Once you have done your ink mark with either using a pendulum marker, or you're doing it based on slit lamp, or you're using a bubble marker, the app will be provided with on Android. You have to take a baseline photograph, and during this baseline photograph the patient needs to fixate on a distant vertical object, and this photo is uploaded over the internet to our server. The server has all the logistics to take care of where these ink marks are. So it will process and it will give you back the images. So this is a short demonstration of the upcoming Precision Anywhere. We're just trying to parody the cashless anywhere that government is saying but not implementing. So this is a parody of that cashless anywhere. You do your ink marking, and after that with the app you can hold the mobile anywhere, anyhow. It just has to be on a vertical orientation. Take multiple pictures, 3 or 4 pictures of the patient. This is a ring illuminator which we use to have a good quality image. Basically the only thing it does is it provides a good illumination for the photographs to be taken. Once the photographs are taken, you have to attach the demographic data. You select a photograph, attach the demographic data. So the patient name, the patient MRD number, and the patient's eye, and then it is uploaded to the internet. Once it is uploaded, this is the image that you get back from the software. So currently the software, the protractor is going to come, but currently the software is going to identify where the limbus is. So this is a step which in Dr. Saurabh's system as well as in other systems you have to do manually. In our system, the whole thing is going to be automated. So the limbus is going to be identified where the limbus is. It is going to identify where your ink marks are. So let's say this ink mark is at 0.1 degree. For demonstration purposes, the ink mark here are made in the computer, but it basically recognizes this ink mark as 0.1 degree. So it is fairly good ink mark. It was supposed to be at 180. 0.1 is not bad at all. And then these 4 other ink mark locations are demonstrated. So now you have 4 places where your Mendes ring, you can put your Mendes ring and have a intraoperatively You can just verify whether your ink marking is proper or not. This software is under development right now and would be available in about a month for download. So the beauty of this thing that we are planning to devise is there won't be any hardware required apart from a smartphone. You can use whatever manual method marking you are using, even freehand marking works. And we provide the robotic precision over the internet. And we are planning to make it extremely affordable, cheaper than your viscoelastic. Another smartphone-based app which is available is Jetwa Toric Marker. This also works similar to Saurabh Patwardhan's marker, which basically gives you these radiating lines with where you have to coincide these this central circle with your limbus. Coming to MNC automated systems, you have Zeiss Callisto I with integrated with IOL Master. This is an automated markerless system. The single unit captures everything and the system matches the accuracy and provides you a live guidance with an accuracy of 1 degree. The pros of this system is it's a system which requires a very minimal training. It's a gold standard system with proven track record, completely non-contact with minimizing operator errors since the data moves transparently, and it's compatible with select EMRs in case you require the data to be used later. The major disadvantage of this system is the cost. It costs about 80 lakhs rupees, 70 to 80 lakh rupees for the hardware and then other parts, limited to a single system. So even institutions find it difficult to have multiple. Works with Zeiss microscopes only. Alcon also has a system which works with other microscopes also. But this is a limitation of Zeiss, and still even with a Callisto or Varion, the errors can creep in terms of if your reference image is poor, if you have significant conjunctival chemosis, if there is a large subconjunctival hemorrhage, and extremes of anatomy like deep set eyes and narrow palpebral fissure along with a very badly uncooperative patient. So this is basically how the Alcon system works. It identifies the limbus, it identifies the blood vessels around the limbus that has there in the preoperative baseline image, and from that it calculates where your toric IOL should go. Another system which is available is Alcon Varion image guidance system. It is again a markerless system, and this requires a reference unit. This reference unit does not provide you biometry, but it actually calculates all of your corneal and limbal anatomy beforehand. And your Alcon Varion provides you with a vision planner which allows you to have multiple incisions and calculate the effect of all of those incisions along with astigmatism management for your astigmatism management. We have a second system which is currently in the market. This is called Precision Toric Guidance System. This is basically similar to Alcon Varion and Callisto. The previous system that I had shown is internet based, so anybody without any kind of hardware can use this, while the Precision Toric Guidance System requires you to have specialized hardware. Basically it requires you to have a computer attached in your OT. This requires a single mark. The Precision app, you can have multiple marks, and the multiple marks will be tracked and you will get a data, but there won't be any live data intraoperatively. Precision Toric Guidance System gives you live real-time guidance. So again, the baseline system, the basic working of the system is same. In this Precision Toric Guidance System, you just do one mark, while in app you can do multiple marks. Baseline photo is taken and this photo is used by the system for guidance. Video has not come. Okay. There's another system in development by Dr. Jagdeep Kakadia. It is called LaserX, but it is the details of which is not available as of now. Then if you are lucky one having access to a femtosecond machine, Lensar comes with a femtosecond laser platform in which the capsulotomy comes with these small tags. So these small tags are there forever. You just have to align your toric IOL to the tags, and these are created during its capsulotomy system itself. So probably the easiest thing to use. But again, mainly the problem in India is cost. Capsule laser is a very, very interesting and very exciting thing. it doesn't do anything for you in terms of toric marking, but it provides you with a very nicely centered, very precisely controlled capsulotomy. The beauty of this is, again, all of your toric results are dependent on your post-op fibrosis. So if the post-op fibrosis is more, post-op IOL rotation is more, then all of the things that you have done previously go down the bin. Coming to the even more exciting things, there's something called light adjustable IOL that is FDA approved in 2017. The company says test drive your vision. What do they mean by that? You basically put a light adjustable, you do your calculation, put a light adjustable IOL in, ask the patient to wear UV blocking glasses for some time, and later on you can have multiple sessions in which you can change the refractive power of the IOL. You can change the spherical equivalent of the IOL, you can change the toricity of the IOL, and this can be done in multiple sittings. Once the patient is satisfied with the IOL, the entire IOL needs to be exposed to their UV machine, and that locks in the treatment. So this is the study that LAL have published, in which the spherical correction, the adjustment they were able to do was from -2 to +2, and cylinder from 0.75 to 2 diopters. So basically it takes care of most of your astigmatic surprises as well as your spherical surprises. After adjustment, 92% of the spheres were within 0.5 degrees, 82% of the cylinders were within 0.5 degrees. While in post, even more exciting was in post-refractive eyes, 74% patients were within 0.25 and 97% patients within 0.5. So I don't think there is any other technology which gives that kind of precision to us. The cons, it is a significantly costly affair. Even in Europe, where it is available, it costs about 4,500 euros more than your average surgery. So converting that to Indian rupees, you would get approximately 2 lakh rupees per eye, more than what is going to cost the patient otherwise. It requires a minimum pupil dilatation of 6.5 to 7, and the patient needs to wear a UV block till the final lock-in is done. Otherwise, God himself will lock everything in. So that's a big problem. This is another system that is again very, very exciting. This is a perfect lens tech. It allows they are saying that they will be able to in vivo modify any intraocular lens that you have already put in. What they do is they change the refractive index of the lens itself. They're using a femto laser to cause photo-induced hydrolysis of the IOL material itself. So you are actually disrupting the IOL material itself, and as a result of that disruption, your aqueous will seep into the IOL and it will change the refractive index of the IOL itself. So any IOL that you have put in, you just change the power of that IOL. Refractive index change of 0.01 provides 3.3 diopters of actual change. For our normal cataracts, we only know of the millimeter change in axial length. 1 millimeter change in axial length is going to cause about 3 diopters of change in refractive power. Here, a 0.01 change in refractive index of the lens allows 3.3 diopters of actual change in the IOL. It works with hydrophobic as well as hydrophilic lenses, and again it is infinitely repeatable. This is their study in which and they claim that they are able to change a multifocal to a monofocal and a monofocal to a multifocal. So this is their study in which they have published. The patient began with the trial eye began with a multifocal lens of 20.85 with an add of 3.58, MTF of 0.37 and 0.26 for distance and near, and ended up with a monofocal of 21.04. So you started with a 20.85 multifocal, you ended up with a monofocal of 21.04, and you also have the option of again repeating the treatment on the same IOL. This is something really exciting. Second, they started with a monofocal of a 5.27 diopter with an MTF of 0.53 and ended up with a multifocal of 5.25 and 8.83. So I have 3 diopters add, and the split is also nice at 51:49. So a little more than what we are used to for near, but still you start with the monofocal and end with the multifocal, and the possibility of repeating this also. So this system, I think, is the most exciting to any person who's having access to a femto laser kind of machine. The cost and other things are not really available right now, but it is under development. Lyric is another system which is again based on femtosecond, but here instead of tackling the lens, they are tackling the cornea without opening the cornea. So what Lyric is doing, very low threshold, below the ablation threshold, to basically alter the corneal shape without disrupting the epithelium itself. So what they are doing is they are creating a lenticule within the cornea itself without cutting the lenticule out, and they are claiming to use it as a first line therapy to treat any kind of myopia, hyperopia, as well as for higher order aberrations. It is neither an additive nor a subtractive procedure. Just whatever layer and the thickness that they say in which they are altering the cornea is just 10 microns. So I don't think even our most efficient smile machines or any other clear machines or any machines can go up to that level. And this again is a repeatable method, because you can just go to a higher or a lower, higher or a below corneal layer and repeat it. But both Perfect Lens as well as Lyric are yet to be FDA approved. So thank you very much for attending the IC. Thank you. If there are any questions. Thank you.